I want to welcome you. This is 2021, and this is all about neurology or functional neurology. That's what I want to do. So what I'm going to do, starting today, actually, this is the kickoff, like I wrote. What I want to do is every 2 weeks, I want to be online. I want to be on the air, on Zoom, on Instagram. Maybe we'll also do something on YouTube. And I want to talk about functional neurology, or neurology in general, but with more with the functional aspect of neurology. And of course, not only theory, not only looking at anatomy, at vestibulospinal tracts, stuff like that. Also, of course, talk about practical application. Because what good is a theory, what good is knowledge if you cannot apply it? So that's what it's supposed to be. So it's going to be applied neuroscience. That's what we're basically doing here. And talking about science, that's always a hard term. Of course, none of this is evidence-based. That's what I have to say, honestly, because this is still a young discipline. And yes, there is functional neurologists in the United States. They call themselves that. Maybe they have an official term for that over there yet. If I call myself a functional neurologist in Germany, everybody looks at me and says, "What are you?" And they think I'm a neurologist, and they think I deal with Parkinson's and things like that. I said, no, I'm not a neurologist. I consider myself a neurologist in a way, but more from the functional aspect and not only concerning neurological diseases. So what I want to do is just give you an intro. So what I plan is like half an hour, 40 minutes every 2 weeks on Thursday nights, 8:30 p.m. in English, 7:30 p.m. and I'm talking about German time, Berlin time in German. So if you have any German friends, you can tell them, you can give them the link or tell them about it. And of course, also English-speaking people, you think somebody is interested or might be interested in what we do, just tell them about this, and we'd be happy to have more and more people here online to talk about functional neurology. This is completely for free, and of course this cannot replace a whole seminar where we go into a lot of details about what we do, but this is basically giving you a good view onto what we do here in Germany, what we do with functional neurology here in Germany. And yes, we will give you practical things you can use in your practice. Probably not today. Today is more general intro and what's happening. And so what I want you to do is you can use the chat, and I gave you the permission to be to join the discussion. So later on we can go into a little direct live chat. Right now what you can do is you can use the chat, and I have to turn that on here for me. Use the chat, and you can tell me what you would like to hear in the future about what things, about what symptoms, diseases, whatever. You want to hear my opinion, or you want to hear my approach. How do I deal with that? How do I deal with back pain? How do I deal with shoulder pain? How do I deal with headaches? How do I deal with psychological issues, emotional issues? How do we deal with that? Because all of these things are in some way neurological. But, of course, there's not only neurology, so we have structure. So if we have a herniated disc, which is really pushing on the nerve, sometimes you just don't stand a chance doing something biomechanical or functional neurologist-like. You just have to get in there with a knife and take that thing out. Also, you can have biochemical issues. Like one thing I'm very concerned about is like iodine. I think that's the right term in English. Sometimes I might think of the term and might say it wrong. So iodine, there's a very large population in Germany who has a deficiency, especially kids. So when we test our kids here in my practice, about 80% of them are deficient, some with a severe deficiency. And why is that interesting for me? Because iodine is one of the aspects, or one of the nutrients that's important for brain development. I don't know if you guys use the same term. In German we say Kretinismus. Le crétin actually comes out of the French and is somebody who doesn't have a good brain development. So we probably don't see much of that, but I just had a young lady, she had severe issues, skin issues, asthma, and also psychological, emotional issues, and she was severely deficient in iodine. So, of course, it could be due to a dysfunctional tract, not having good resorption, which could then be a neurological problem. So the whole biochemistry is not managed or regulated well, and yes, that could be resolved with functional neurology. But if it's not there in the first place, and not very many kids here eat fish or algae or stuff like that that contains iodine, so, and also the supplementation is not enough, so then you have to supplement it. And that's one part we're looking more and more into, is what types of supplementation do we need to enhance brain development and brain performance. Neurotransmitter systems, one issue that we're looking into deeply at the moment. Of course, to build neurotransmitters, you need amino acids. So that has to be there. It has to be in your stomach, in your intestine at first. It has to be, it has to go in your blood. It has to be taken care of by the liver, etc. So there's a whole bunch of things that have to go on, and at some point it can be neurological. So there we have a nice thing going on between regulation of the chemistry through neurological functions. So even if somebody is deficient in something, I still look at the systems who are supposed to take that nutrient out of the food. So I had a girl who had a chronic iron deficiency, and even though she was supplemented, she couldn't build up iron. Why? Because she had a dysfunctional, dysfunction in her autonomic nervous system of the belly, of the upper gastrointestinal tract, and of the liver. So in that, resorption through the intestine and storage and things like that through the liver, that was dysfunctional. So we treated that with functional neurology, and then her iron just went up without supplementation because she actually had enough in her food, but she couldn't resorb it. So that was a nice example of biochemistry going wrong due to a problem in functional neurology or a neurological function. So there's a whole bunch of things we can talk about. I have so many things in my head, and of course now we have like a half an hour, 40 minutes. I can just get into some very basic things, and then I do want to get into very specific aspects of body functions, whether it be movement, sensory system, exteroception, interoception, emotion, cognition, all these things. There's a whole bunch of things we can talk about, and what I would like to have is some ideas that you have, what you would like to hear, so I can pick those things up and tell you what I think, how that should be dealt with or how that can be dealt with. And I have, besides looking into biochemistry more and more, from the neurological aspects, I work with two modalities right now. So one is just using functional neurology, neurological integration. We called it that. Now I'm calling it neurofunctional integration because we're adding in a lot of functional testing, actually. So that is one aspect we use. And then we have the aspect of training. So what's the difference? One thing is an integration, and what I see or what I believe we deal with here is dysfunction. So it's something that's not functioning, because what's not functioning, it's like a bad current, something's not going, so you can't train it, you can't enhance the performance by training because it's just not working right. So that's what we would say that goes in the category of dysfunction, and that can be dealt with integration. So we're going to talk about the aspect of integration, of course. And then the other aspect is what neurologists or neurobiologists call learned non-use. So if I just sit in my chair all day, my vestibular system is going to go down. And if I then decide to move more and my vestibular system cannot adapt correctly because maybe there's too much input at one time, this might not be dysfunctional, and that's what you can test if it's dysfunctional, but it might just be, the function might be lower or maladaptive. So that's something you could maybe possibly train. And one aspect of training is to destack. So that means to regress in terms of do less. So don't go out into the woods and do some trail running. So you have too much input, visual, vestibular, proprioceptive input. You might just regress it to training one part of the vestibular system. So you might have a low function in your horizontal canal on the right side. So you might need to train that explicitly, and that's what we do with neurofunctional training. We call that, another term for that is also neuroathletic training. So you can actually differentiate in the testing if it's more dysfunctional or just low in function or in a bad function because of learned non-use. Might also be some other reasons for the system not to work well. And then you can treat the dysfunction in your practice, and you can give the patient some homeworks according to the tests you do with them, and give them homework and say, you need to train your eye motion, you need to train your vestibular system, you need to train your proprioception. How do I train my proprioception? Saying, well, when I move, I train my proprioception, but yes, maybe there's too much going on, the brain cannot integrate all the data that's coming into the brain. So then you might just want to give sensory stimulus to one area. For example, I had a patient who had a problem with his arm after a stroke in the pons and in the medulla. So one aspect, of course, was looking what can we integrate, and the other aspect is what can he train. So part of the training is just give specific stimulus to the arm, and then we looked at what specific stimulus was the best stimulus his brain could for the brain to enhance the performance. And I'm not talking about performance in terms of high performance athletes, but just daily performance. Just a regular guy with a dysfunctional sensory and motor system in his arm after a stroke. So vibration was one of the aspects, or pinpricks, so something that's pricking. So you have vibration more activates more the proprioceptive system, and pinpricks more the interoceptive system. So those two modalities, and then when he would go over his arm with that a few times a day, that would improve the function and then also the symptoms because the brain was getting more information. So that's the two modalities, and there is of course some neurophysiology going with that. So we think that dysfunction is more an electrical problem, a signaling problem, and the other thing is more a structural problem, a neuroplasticity problem. So if I have a circuit in my brain that's intact, it's not dysfunctional, but it's just not robust, it's not big enough to deal with the information. I have to tune it up by training it, by getting to get more neurons working for that specific part of the body or that specific function. So that's more the neuroplastic thing, but not everything is neuroplastic, so I don't have to train everything. I can integrate things, and that of course is a lot faster. So this combination of integrating dysfunction, neurological dysfunction, and training neuroplasticity aspects, that gives us a real nice combination in practice to deal with a whole bunch of problems. Then, of course, combined with a biochemistry to see what kind of biochemistry deficiencies are there, but also on the other hand, of course, what's maybe there that's too much. Toxins, toxins from food, toxins from the environment could also inhibit, and a lot of toxins are neurotoxics, the process. So that's also one aspect we're looking into more and more to see how good can somebody detoxify. Genetic polymorphism is one aspect of, well, maybe somebody cannot detoxify certain agents in his body as good, so he needs to do something for it in addition to his body working like it is. Okay, so those are a couple of aspects, and what I want to get across to you, not only today, but of course in the following weeks and months, is kind of a viewpoint. What's my viewpoint of neurology and strategies? How is the thinking? And that's one aspect. If I have a whole lot of knowledge, I don't have a structure in that knowledge, I might not be able to apply that knowledge. So that's something that's very important for us, is to give that knowledge a structure. Is like, what is my thinking? And I just want to walk you through that in a very basic way. How do I think? How do I access a patient when he comes in with a certain problem? Let's say he has a hip pain. So we kind of divide into 6 different levels of function, and of course there's a whole bunch of aspects in each of those levels, and I just want to give you a few examples of what could be going on and what's going on in my head when this patient is coming in. So of course, first thing I want to see is some kind of radiography or X-ray or something like that, or MRI, see is there a structural problem, because if you had an accident, there could be something that's torn in there and it needs to be fixed or repaired through surgery, of course. So that if that's excluded, if there's nothing, and it's not an arthritis, and it's not worn out, the joint, and nothing is broken, so we could assume maybe it's a functional problem. And I think it's very interesting when I talk to people and they're saying, yeah, I'm doing like functional things, like saying like, yeah, do you consider the vestibular system? Do you consider the eyes? Do you consider the spinal cord, the brain, the nerves? And it's like, no, I'm not doing that. It's like, how do you define functional? Yeah, like who is giving the system a function? Of course, it's mechanics, but it's also a lot of neurology, a lot of brain, a lot of input, output things that are giving the system a function, a certain function. So, so patient comes in, he's got a hip pain. So there could be different strategies in terms of what kind of a history does the patient have. And yes, so the strategy I'm telling you right now could be a strategy not for somebody with brain injury or brain trauma, but somebody maybe who had a trauma, fell off the horse or the bicycle, 10 years ago, and since then the hip has not been really working that well. So my thinking is I have 6 levels I need to look at. The first level is receptor level. So we have this idea, and this is what some people say, input, process, output, which is, in my view, not that true. But of course, the input to the brain is very important. Why? Because it needs to correct the output. So if I'm moving my hip and the feedback to my brain is not good because all the receptors in the skin and the fascia and the bone, or in the skin of the bone, all that is not good, I can't move that well, or I can't correct movement that's maybe not that good. So I want to see how the receptor function is. So I'm basically testing through all different receptor modalities, about vibration, about stretch, about temperature, and all these things local. And there I have an approach going from outside to the inside, because already when I move, my hairs are moving by my pants or by the air that's going around my feet. So if I'm running with shorts and maybe it's not my hip, it's my knee, then there would be air moving around my knee, moving the hair, unless I'm hairless. Or if I have a hip problem, the rubbing of the clothes on the skin is moving the hairs. And you have 2 types of receptors in your hair: proprioceptive receptors and interoceptive receptors. So could be an interoceptive issue, warm, cold, something like that. Could be proprioceptive, like what do you say, a pull on the skin or something. So if that's not working, and that's very interesting to see sometimes when I test people, saying, okay, do this, do that. We do some muscle function testing, we do some movement tests, and then I just apply like air to the skin. And you can just wave a piece of paper or something to it, or you can use something to move the air, and then all of a sudden the system kind of breaks down. The function is not there. The muscle goes weak. The function is the mobility is gone. The gait pattern is off, showing how easily the system is influenced or made dysfunctional by sensory input. So that, of course, needs to be fixed. So you need to go, or we go through all these sensory modalities, starting with air movement, and then going to the skin, movement on the skin, then below the skin, more in the fascia, then more into the muscle. Do the spindles and the tendon Golgi systems work? Do the ligaments function properly? So what happens in a knee if I have a problem with my cruciate ligament? So not torn, not partially torn, just normal in the structure, but dysfunctional from a neurological aspect. So how could the reflex between the ligaments and the muscles work if the sensory input to the ligament is dysfunctional? So sometimes you have to find that specific ligament, like the cruciate ligament or the collateral ligament of the knee, or some tendons of the biceps, or tendons of the Semitendinosus, we say in Germany. I think it's should be pretty much the same in English. So there could be very specific dysfunctions in specific parts of the whole system: skin, hair, skin, fascia, muscle, ligaments, joint capsules, of course, bone. Yeah, I have patients who had fractures of the bone a long time ago, or that was very interesting. A patient who had actually had back surgery, and since then he had sensations in his legs, and not really where you could say, well, that's very normal because of the surgery that gives you the sensation. And it turns out that the sensation in the right leg he was experiencing was coming from an old fracture in his left leg, and I'm telling old 40 years ago. He had a severe fracture of his lower limb 40 years ago, and as soon as I applied certain aspects of sensory information and like vibration applied to the bone on the side where he fractured it 40 years ago, started the sensation in the right legs, giving like tingling and pain and things like that. So we actually had to work on the old fracture of the bone. We had to treat the skin of the bone. The bone, of course, itself is not innervated, but the skin around the bone is innervated very densely, and if that's like giving misinformation for 40 years and now it's becoming symptomatic because of the back surgery, well, you have to treat the bone that has been broken. So that all the way down to the bone. So that's all like peripheral things we do with functional testing. We say receptor of the receptor sites. And next thing is you have to take care of the nerve, of course, because that's supposed to transport the information from, let's say, the hip to the spinal cord, first of all. And a nerve is a very fragile structure. You can't really say that because if you see a nerve, it's very tough. It's very tough tissue, but it's not very flexible. I think nerves have an ability to stretch by themselves of maybe 10%. So it's not a lot. So the movement of the nerve is not so much stretching of the nerve, it's more the movement of the nervous system. And so there's a whole bunch of mechanoreceptors in the nerve. The term in German or in Latin is nervi nervorum. So those are the nerves of the nerves, looking out for the nerve for its mechanical properties. Also, along with those, you have nerves that look out for the biochemical properties, because at the same time that it's like such a robust structure, it's using up a lot of energy. Yeah, so the nervous tissue is using a lot of energy. So there's a huge blood supply everywhere where there's nervous tissue. Yeah. So that can be disturbed. So the nerve itself as a biological system can be disturbed mechanically or biochemically, or in its biochemistry. So you have to look at the nerve, you have to look at the nerve function, the mechanical and biochemical, am I saying that right? Function of the nerve going from the spinal cord to the receptor site in terms of afferent or efferent. I didn't say that. Of course, we test function, specific function, in terms of somatomotor function, also in addition to the sensory function. So the nerve is our second level where we say, okay, we have to test receptor function, we have to test nerve function. Then we go to the spinal cord, and here it becomes quite interesting because here everything like that patient I was just talking about, left and right are connected, yeah, front and back are connected. So here you have an integration process of information going out and into the system, and so the spinal cord level must function. I thought it was very funny when I first learned functional neurology. Is like, oh, the spinal cord is just, it's just a bunch of cables, Absolutely not. The spinal cord is part of the brain. It has integrated function. It can decide on its own. It manages reflexes. So you can have a problem on the level of your spinal cord, giving you a problem in reflex management, and not only somatomotor reflexes, but also autonomic reflexes. So what could be wrong on the spinal level? Yeah. So we think biomechanics. We think, oh yeah, maybe you got a what do you call that? Subluxation is what somebody who's coming from chiropractic would say. But we're also looking at autonomic function in the spinal cord. So you have, if you look into an anatomy book, how many blood vessels you have on the level of the segments. That's just incredible. And I see a lot of people who maybe had an accident. I don't know, they fell off the horse. That's something I see very often for some reason. A lot of people horse riding here in Germany, in the south of Germany at least. And they can fall off the bicycle or have a car crash, and they can have a contusion to their spinal cord, and that could cause autonomic dysfunction in the spinal cord, which could in turn then cause dysfunction of the spinal cord in terms of reflex dysfunction, movement reflexes, autonomic reflexes of the peripheral arteries, for example. So that is an aspect, of course, that has to be looked at. The spinal cord has to be looked at. The spinal cord has to be treated as part of the brain, as an integrative part of the brain, and also as an autonomic part of the brain. The brain tissue or the nervous tissue is very high in metabolism. So that's one thing that we deal with firsthand when we say we have a dysfunction in parts of the nervous system, especially of the central nervous system. We first look at the autonomic aspect of that. Is there a problem with the lymphatics? Is there a problem with the blood vessel, blood supply? Things like that. So that has top priority when we look at those things. So that's one thing. What is also very interesting in that part of the brain is, of course, that part of the brain, I'm saying the spinal cord, is the segmental aspect of the connection, not only to in terms of autonomic, not only to the blood vessel supply of your muscle or of your tissue, but also the nervous supply of your glands, which gives you an interconnection or a reflexive connection between glands and of course your muscles. A lot of people who have done some sort of functional neurology or osteopathy, or they know about these things, and that's one thing that's very important because, well, if somebody comes in, say all of a sudden my hip was hurting, that could be caused through an infection of the bladder, for example. That infection could be long gone, but it could have caused neurological dysfunction, lasting neurological dysfunction in the pelvis, then giving a dysfunctional pattern in this autonomic nervous system connected to the bladder. So you can have foot pain, knee pain, hip pain, back pain, all these things coming from the dysfunction in the autonomic nervous system. And like I already said, autonomic nervous system for us has absolute top priority. Before we look at somatosensory dysfunction, we look for autonomic dysfunction. So that's spinal level, very interesting. Blood supply in the spinal level, reflexive systems also going to the glands, and then of course we have to take care of that. Is that also, can you also train that? Basically, yes. I mean, if somebody had surgery in his stomach and he's got a bad function, not a dysfunction, maybe he needs to train his interoception or his autonomic motor system. Breathing, something we use quite a lot. What kind of breathing techniques can you use? Hi, Brunhild. Brunhild, I can hear you. Genau. Maybe you want to switch off your microphone or use English so I can understand if you have a question. All right. So I'm just going to get some other guys the chance to become, thank you for joining us. I'm just out of the picture just for a second here. And so we can go into discussion in a few minutes. Scott, I can see you now. Nice to see you here. Thanks for coming by. Okay. So you will have the opportunity to get into a discussion with me in a couple of minutes. Okay, so where are we? We are at the level of the spinal cord, and I want to jump up to the level that's what we say is our third level, is the brainstem. So brainstem, of course, very integrated function already in terms of autonomic regulation, basic functions, walking patterns are mostly organized in the brainstem and in the spinal cord, just modulated by the cortex. So I'm not moving my hand in a certain way just with my cortex. Most of that is coming from the brainstem. It's just like organized and integrated to the environment through my cortex. So brainstem is a lot of basic function, very integrated. Level of the spinal cord integrated in the segmental parts, brainstem integrated of the whole body. So you have all your biochemistry there, and of course you have your basic movement patterns, like I said, breathing pattern, of course, very much organization in the brainstem. Not only. So Then there's the connection part of the top brainstem, which is connecting those reflexive basic functions in the brainstem with then higher parts, which is the midbrain, what we say, and I have a little bit have other terms than you might read, but I'm just going to explain that in a minute. And then of course you have the cortex. So brainstem, very important, probably the hub for most of the things we do. And when I say brainstem, I don't only mean medulla, pons, and mesencephalon. I also mean cerebellum. I just have a little bit of different nomenclature there. So that's one part we deal a lot with, and brainstem dysfunction is quite common, especially if people have like whiplash injuries. Whiplash injuries can cause brainstem dysfunction, also because of, and that's what we look again, of autonomic dysfunction in the neck. If you have an autonomic dysfunction in the neck with your blood vessels and the blood supply to the brain is not taken care of really good in your altering functions, you might have a problem. So we see a lot of that. We see a lot of blood vessel dysfunction in the neck through whiplash, but also through traumatic brain injury, which often goes hand in hand with whiplash. And we have 150,000 traumatic brain injuries every year in Germany. So that's a whole lot. And that's what I said before. So if somebody comes in and said, I fell on my hip, I probably would start here with the hip and work myself up. But if somebody said, I have hip problems, but I fell on the head, of course I'm going to start with the head, because it could be that, and we know that by now, that already mild trauma to the head can cause dysfunctions of the artery supplying that part of the brain over a long term. And we're not talking about I fell on my head. It could be just I got up and hit my head on something, I don't know, on the table or whatever it is. So it's mild traumatic brain injury can already cause autonomic dysfunction of the head. So the head has become, because also of course it's the hub of the brain, has become very interesting for us in terms of how we look at it from an autonomic point of view. The innervation of the blood vessels, the innervation of the lymphatic tissue. You know that lymphatics have not only been found in the skull, but also in the brain, what they now call the glymphatic system. So all of these things have to be regulated. The the ascending autonomic reticular system, activating reticular system, that's what it's called. Neurotransmitter systems are very interesting in that term. So a lot of things to look at there. From the brainstem, also midbrain, which is basically things like hippocampus, amygdala, all that kind of stuff, giving a little higher regulatory aspect, higher goals. And with higher goals, I mean not just I'm getting up, I have to regulate my blood pressure. It's like, oh, I'm hungry, I have to find some food to eat. That of course then works with memory, like where was I last time I found really good food for me. So that's coming in there. Also a lot of emotional aspects coming in there. Not talking about the limbic system. That's one of my favorite things. And saying, oh, that's the limbic system. I said, no, it's not. The limbic system is just a term somebody used to describe anatomy, not function. Okay, so we're never using limbic system unless explaining that the limbic system is not what it's used for. For some reason, the limbic system has become the emotional brain, and that's absolutely not true. So, but that's things. That's going a little bit detail. So that's the mid part of the brain where you have all the experience you have, and you have the basic motivations like I want to stay warm, I need to eat, I need to reproduce, all those things that are managed there. And then of course we have the cortex, which is a little overestimated, I think, in terms of what we deal with on everyday basis with a patient, unless somebody has a brain injury or traumatic brain injury. But a lot of function is what I think more basic, which has to be dealt with. And of course the cortex comes into play when we talk about interpretation of the environment, putting those two things together. I'm hungry, I smell something, I can move, see where that smell is coming from and see if that's interesting for me to eat, so I get more energy. So there the cortex comes into play a lot. And then of course creativity, which is something that's very good because we don't live in caves anymore. I have this possibility with the camera and with computers and with the internet to talk to you guys across Europe, which is awesome, I think. but also creativity, of course, is something that makes people sick because they think they have something, and then we have to differentiate between being sick and feeling sick. And so that can be a brain dysfunction in terms of interpretational sickness, maybe you can call it that. And that, of course, goes into then mental training, seeing people have a thought pattern that might cause them discomfort, to see how they can get out of that thought pattern. It's very interesting to work with that. So we do a lot of that mental work, but also before we do mental work, we have to make sure that those systems that we need to interpret, like the temporal lobe or the visual system, to identify things and see them the way they are, not see them the way we think they are, to make those work. But if I have a traumatic brain injury, if I fell on the back of my head and the blood supply to the back of my head is not doing well, then I might misinterpret what I see, which then might cause discomfort, emotional and physiological discomfort. And of course, first of all, I have to take care of that physiological aspect. So one thing I would like to talk about, and I will talk about, unless you have things, you have a lot of things that you want to hear, I could talk about. I want to talk about fear, and I want to talk about panic, because I think there's a great misconception about how people are treated psychologically, because they think, oh, panic is something that's caused by thinking. Probably most panic is caused by physiology gone wrong. Yeah? Whiplash causing dysfunction in the cranial nerve 9, very common in people who suffer panic attacks. Why is that? Well, it's measuring the blood flow to the brain, it's measuring the oxygen, it's measuring the blood sugar, it's measuring the insulin, it's measuring the carbon dioxide. And if it's not measuring correctly because it's dysfunctional, well, what's the brain going to do? It's like, oh, I'm running out of energy, I better do something. Now adrenaline is pumped into the system, and now you have a panic attack, which is just by wrong measurements in your carotid artery, for example. All right. So that was like a fast track going through the way we approach. And of course, like I said, I could approach it from the peripheral aspect, I could approach it from the central aspect. And in the end, I always do both, because sometimes people come in and they don't remember that they fell off a tree 30 years ago, causing a dysfunction in their cranial system, in the sutures, in the trigeminal nerve, in the sympathetic nervous system, in the blood vessels, cranial nerve 7, cranial nerve 9, etc. So that has to be taken care of, and that has to be found. So that's a lot of course, thinking, a lot of testing, and it's just a matter of where I start. And that's also always one thing that's been asked at the seminars, like, where do I start? And it's like, okay, think. But thinking is not enough. You have to know. You have to have, of course, knowledge. And this is for me, what this is all about. Is what do I need to know about neurology, about the anatomy and the functional neurology? And if somebody comes in, like a patient of mine who came in and said, I eat something and my energy system crashes. So, well, what's managing the energy? What's managing the blood sugar? Is it the adrenals? Is it the pancreas? Is it the liver? Is it the vagus nerve? So maybe it's because the vagus nerve is impinged in the jugular foramen, because they got hit on the head in a car accident, the back of the head. So now you have a dysfunction in the vagus nerve, now you have a dysfunction in your blood sugar regulation, and now you have maybe not panic attacks, but you don't feel comfortable after eating. So where is it coming from? What could it be? What are the aspects I need to check? Is it sympathetic or parasympathetic nervous system? Where do they go? Do I have a problem in my spinal cord? Maybe through a trauma in the spinal cord. Bad blood supply regulation, I should say, etc., etc., etc. So, very short, compact overview into my way of thinking functional neurology. And of course, I want to give you stuff you can use practically. We're going to talk about movement patterns. That's something very easy to test. I will have somebody here with me so I can show you the approach, the how do I look at things, how do I think about things, and how do I treat things. Some people listening probably have experience in functional neurology, have their approaches. Maybe I have some new approaches for you. Some of you guys listening, thank you for coming by. We have met with our former teacher, my former teacher. Maybe you're still being taught, Dr. Phillips, of course, and still a lot of that thinking in my head, but the approach has changed quite a lot because it's a lot more functional, it's a lot more involvement of the patient. The patient has to do, the patient has to move, the patient has to activate his own nervous system, not only in a passive way, but also in an active way, because that switches the way the brain is working from passive to active interaction, and that makes a difference in testing, and that could be something that's needed, that you need to do to get the dysfunction, to see the dysfunction, so you can then figure out a way to treat the dysfunction. All right, so I'm just going to wrap it up here. I would really, I hope you took something out of this. I mean, this was an intro. This was the first day of our NeuroThursday. That's what we call it. We're going to be here every 2 weeks. 8:30 p.m. And I will get more specific. I will have presentations. We're going to look at anatomy. We're going to look at physiology. We're going to pick out certain things and see those through. And then we also, of course, want to do some practical stuff. And if you want to share this information, this link with others, you are very welcome to do so. Everybody who's interested in medicine should be interested in neurology, from my point of view, because you can't just rule out one system, say, I'm not a neurologist, I'm not looking at the brain. Well, back pain, dysfunction of the guts, psychological issues, all that is neurological. And that's why I think we cannot go without looking at neurology or considering neurology. We can't do that. All right, so that's why we're here. That's why I'm here. I want to talk about it. And you are welcome to write some stuff into the chat, information or issues you want to hear about. You can send an email to info @neurolog.de. You can write an email saying, well, I would like to hear about this or that. And what I'm going to do now, sorry, Instagram, I'm going to go into a small Zoom meeting. I'm saying bye-bye to Instagram. Thank you very much for listening. I hope you did understand everything that I was saying, or some of it. I hope there was no technical issue. That's always something that when you go online. So I say bye-bye. I thank you a lot, and I'm going to end this. Thanks for joining us. We'll be back in 2 weeks, same time, same place. Bye. And I will stay around for Zoom. Okay, I'm going to switch my camera. I'm going to go to my laptop camera so you can see me nearby. Or actually, I can stay here on this camera. This is a little nicer. So you guys, if you want to, you can turn on your microphone. I have you right here on my ear, so I can hear you, and you can talk to me. You can also turn on your cameras if you want to. I'd love to see you again since we haven't seen you. Thank you, Richard, for being on. Hello, Susan, right? Oh, great. Thanks. Yes. That's awesome. Yeah, thank you for being here. And like I said, if you want to ask me some questions, the advantage you have, nobody coming after you. I'm just going home at some point, so I'm willing to chat with you. If you don't want to ask neurological questions, you can also chat with me, since we haven't seen each other for a while, or we haven't seen each other at all yet. So who wants to chat with me? I can hear you right here. I have you right here in my ear. You need to, of course, turn on your microphone if you do want to chat. I hope I have that turned on. Thank you. Yes. Yeah. Well, basically, since he had a fracture to the bone, I actually started with the bone on that side. But you always have to keep in mind that the bone was the part that was broken. Although his fracture was so bad, he almost lost his leg. He almost got an amputation 40 years ago. And so there was probably also a lot of damage to the soft tissue. So, but there I started with the bone. You can go anyway if it's quite obvious where the problem was also, then you can start there. Otherwise, I have this idea of going from the outside to the inside. So I'm like starting with the air, starting with the hair, then go to the skin, then to the fascia and the muscle, and then go to the bone last. But there I went to the bone first because it was obvious there could be something in the nervous tissue surrounding the bone. Yeah, and then you test. I test. A basic modality. So what I actually do, I'm not just testing for the feedback he's giving me. So that's one part of it. So I'm applying some sensory stimulus, and then he's saying, "Oh, now that tingling and pain and burning pain in my right leg is starting, just like I experience it all the time." So I was able to trigger it from the old fracture part. The other part, of course, is how does the body react in a sensory motor loop. So applying the sensory stressor, I want to call it, and then looking what the motor output does, and if the motor output modifies in a pathological way, saying muscles are just going weak in his foot, in his knee, in his hip, that is a sign of sensory motor dysfunction, integrational dysfunction. So, and then what I basically do, and this is just very, of course, not very detailed. I look how I can change the reaction of the body. So there needs to be a second stimulus somewhere, and that's the hard part. Somewhere in the body, somewhere you have to stimulate the system to get rid of the dysfunction. And so it could be something that's related to the leg or to the nervous system of the leg, but it could also be something very different because, and this is now what I'm thinking, is the signal is going through the receptors, through the nerve, through the spinal cord, through the brainstem, and so on. So it could be I need to activate the brainstem in a different way to give me a normal reaction to the stimulus I'm applying to the bone. So how do I activate the brainstem? I can use the contacts we learned with Dr. Phillips, or I can use a function, like I can let them breathe, I can let them chew, bite their teeth, roll their tongue, whatever part of the brainstem I want to activate. And of course that's always, I think, actually maybe the hardest part, because the patient is saying where his problem is. I kind of have to figure out the interaction, and then in the end I need to find a resolution for it. And that's probably what needs the most time, because sometimes it's just way off from the leg. It's just somewhere, but it has maybe something to do anatomically. Yeah, so the signal has to pass through the brainstem, through the medulla. So if I activate the medulla, and that's making the pathological reaction go away, well, then I can integrate it. But I have to find, of course, what part of the brain needs to be activated to get rid of the dysfunction. So that's the basic idea here. Yeah. So it has become, for you guys who have been in with Dr. Phillips and NIS, and of course I don't exactly know how he has been, where he is, what path he has gone down since 2016, since I was last there. But we have tried, or I have tried, to make it very understandable. It's just anatomy and physiology, not so much interpretation. What that could mean, that was something I disliked more and more towards the end, until I left the NIS group, because I just want to say, well, what do we know about this? Well, we know this is the ear, and we know there's some nerves on the ear and in the ear, and we know where these nerves are going, and we know what these are activating. That's what we know. If integrating the right, I don't know, cranial nerve 8 with medulla, what does that mean? I said, well, can mean a lot, but basically it just means cranial nerve 8 and medulla. That's it. So, a symptom evolving from that, but less interpretation. This was and is my goal, and just understandable anatomy. And I think that most of the time that's enough. Yeah, we don't need to go into more interpretation than that. Yeah, very often. All right. Anybody wants to ask some more questions? You are welcome to turn on. Yes. Yes, same. Yeah. 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 And yeah, that's great. I'm looking forward to, and you can just let anybody know you think who could be interested. Just let them know. Anybody also with we don't need a background. And this is, I mean, we can't turn this into a full seminar, of course. But I think I can get across quite a few basic ideas that you can use in your practice. And what we're planning on doing is having all the knowledge and all the curriculum I created over the past 4 years available in English by the end of the year. So we already transformed a seminar number 1 into an English version, which is going to be available quite soon. And we're doing that in the whole year with the other seminars with the different aspects. So you could even, and that's what we're planning also in these COVID times, to have this available online. And I'm probably also going to do some online live seminars, so like a whole weekend or something, so we can really dig into stuff, because that's my thing. I think first you have to know, then you can apply. Otherwise, you apply something that you don't understand, and I think that's not good. And of course, I'm digging deep since 18 years, and I'm sometimes I might be digging too deep, but I think there's some very basic aspects you have to understand, so you know what you're doing, and so you can also explain the patient what's going on. So I think that's at the top of my priority list is knowledge. Yeah, understand, because I mean that's true for everything you do in medicine. You have to know what you're doing. Otherwise, you're just following a protocol. Just saying, okay, we have a symptom, and with that symptom, I give that medication. Then you don't have to understand how that symptom started. Maybe could be good to understand it, to maybe understand why that medication is not working. But that's physiology and anatomy. That's what it comes down to. And here, especially, of course, neurological anatomy. So I'm very happy to share that with you, and I'm very happy that you joined us here tonight. And I was always keeping back on doing something online, and now I had to, because of course we got shut down last year in the spring. And first of all, I boosted my curriculum. We worked everything through and see what we could do there. And then at the end, we started doing some online seminars. And I really like it. It's kind of weird looking into the camera all the time, but I got you here right below us. I got you on my screen so I can see you. So we're working with a bigger screen so we can actually see who we're interacting with. And I'd love to do some live seminars sometimes again. But there's practical aspect. I mean, if I can stay here without traveling, even if it's not Corona or anything else, we can still stay in contact, which is, I think, very valuable to share the knowledge and stay in contact. I missed you guys. Yeah, I must say that. One of the things that made me sorry of leaving the NAS group. Yeah. We can hook up again this way. Yeah. Yeah, thank you. Okay, Susan, I think you wanted to ask a question. Yeah. Yes, thank you. Yeah, I can see that. Yeah. Yeah, thanks for joining us today. Yeah. 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 Oh, haven't thought about that actually. Just like, yeah, next time, just maybe like a technical question. Did everything work out okay? Did you hear me well? Did you see me well? Of course, that's not only my end here. That's also your end of the line. If your internet is working well. So we installed a very high speed internet line here. So we hope everything is working, but of course, we never know if the signal is always reaching you and you can hear me all the time. So that would be the only question I had right now. Yeah. Okay. Yes, absolutely. Yeah. Yeah, I mean, that's what we deal a lot with. I mean, we deal a lot with that. You might have somebody come in, and sometimes, it's just something like, so, like they're saying like, when I do this and like, then my elbow is hurting, and say, well, yeah, my elbow kind of hurts too a little bit when I do this. But like, what's the big deal about it? And that can already go into misinterpretation. Oh, something might be really wrong with me. Yeah, something, I might be really sick, and this is the first signal of me dying soon, or something like that. So there's a whole bunch of things going into that aspect. And of course, one of my things that I see a lot and I treat a lot is the not fear but panic, panic disorder, yeah, or panic attacks. Yeah, so things I see a lot, and most of those I see are not emotional, they're not psychological. They're more physiological, because people have head traumas, people have neck traumas. So that's can give a whole bunch of dysfunctions to the autonomic nervous system of the head, causing the system to keep crashing and then performing reboots, which they experience as fear. So a whole bunch of things going on there, which I think are misinterpreted. There's one interesting theory, and I'm not sure if I get that right now, is the Klein's theory of panic attacks or panic disorder. And he basically talks about cranial nerve 9 dysfunction, and I think that's maybe a nerve that's well overlooked all the time. Everybody's talking about the vagus nerve stimulation, vagus nerve training, vagus nerve here, vagus nerve there. Well, the guy watching out for the brain, the vagus nerve is watching out for the brain also, but also for the body. So it's sitting in the aorta and measuring the biochemistry in the aorta. So that's the blood going to the body. But the cranial nerve 9 is sitting right here in the carotid, looking out for the biochemistry and the blood pressure going to the brain. So it's like the gatekeeper of the physiological function of the brain, one very important one. So if that's dysfunctional, you got a big problem, because your brain is under constant stress. And one aspect of stress then is maybe irritation, or the next level is fear, and the next level is then panic attacks. So very, very interesting. And over psychologized, well, probably not the right term, but I think, yes, some of it is psychology, maybe also in times like these, more, of course, but a lot of it, I think, is physiology, and that's always what I look for first. How does the brain work? Do all brain areas get what they need? blood sugar supply, whatever that is. Look at all those things that regulate that. So very, very interesting. Yeah, huge spectrum of possibilities behind that one symptom of fear. Yeah. Yeah, but like you said, that's nice. I like that saying. What you said, Susan. Information is different from knowledge. Yeah, that's absolutely true, and that's what I seek. I seek knowledge, being well aware that what I'm saying could be proven wrong tomorrow. But that's what I have to work with right now. And if you stay open and if you don't go into interpretation, and when I talk about NIS, and I want to be really clear on that. I'm not questioning the effect of NIS because I saw the effects for years and years. But I disliked the lack of knowledge seeking, general knowledge seeking, so accessible to everybody, not only to Dr. Phillips, but so that everybody could understand. Say, well, that's you can just look that up in a textbook. That's in the textbook. Some things are not in a textbook. You have to look into more recent research, but it's knowledge that's out there. And of course, that doesn't cover everything. We have to always be aware of things we don't yet know. We just see, and I think that's very interesting. Quite often, I see something in my practice, and I play around with it, and I get an interpretation of that. I say, well, that's interesting. There's always this part of the body showing up with that part, and things like that. And then I go looking for it, and sometimes I don't find something. And 5 years later, I look again, and then I find some recent research that says, yes, that's how it is. That's how the brain is working. Yeah, I think that's very encouraging. Yeah. So that's my mission, to bring you there. And I also need you guys, because I think this is something. And I just had a book in my hand. It's called, in German, it's called Neuzeitliche Nervenbehandlung. New Age nerve treatment, maybe that's the translation for it. But the book was written in 1928. Yeah, it's treatment of the nerves. So it's not that new what we're doing, but I think, well, why is that not normal knowledge? So knowledge can go away so fast again. No? So, we forgot about functional neurology, like in 150 years, they think, somebody did that, but, it was not widespread enough. So I think that's what I'd like to have, is like a lot of people talking about that. So in the end, that it cannot be forgotten again. Yeah. So it's just there. It just has to be there. Yeah. Oh, okay. Yeah. 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 I think, yeah. I mean, I wouldn't want to say that we can access everything, but I would like to say that we can access quite a lot, and that, yeah. And no, of course not. No. Yeah. 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 And it always builds on what has been there previously. Yeah. So there's still a lot of NIS knowledge in what I do. I just put the puzzle together different in some ways. Yeah. So just to move on. Yeah. Yeah, and I can tell, yeah, and I can tell you very interesting story I had with Dr. Phillips, because I think that was like 2 years. I mean, I did the first seminar with him in 2003, and at some point I read his brochure on NIS, and it was saying it's all about the brain, not about the mind. And he would always keep saying, don't get into their lives, don't go into psychology and stuff like that. But I asked him about that, and he said, well, you have to see it from a background of New Zealand. New Zealanders, and maybe not only New Zealand, people don't want to think they're confronted with a shrink. That's basically what he said. You know, they don't want to say, I'm nuts. So you keep it to the body. And I think in a way he's very right, because a lot of it is physiological dysfunction. But on the other hand, we are very conscious beings, and our consciousness has a whole a big impact on how our body is functioning. What I believe I can do has an impact, or what I believe, how I feel. Somebody tells me that what I'm eating now is unhealthy for me. That could make me feel sick right away. Yeah. So, and I think we need to take that into account, because also the pain somebody's experience is the conscious experience. We cannot access the unconscious experience because it's unconscious. So it's the conscious experience, and of course into that is a whole bunch of things going into that: interpretation, experiences, knowledge, non-knowledge. If I don't know something, like my elbow, I think it's hurting, it might fall off. No, your elbow cannot fall off. Oh, okay, then I don't have to panic. Yeah. So that's one thing I always also focus on, is like, what do you not know? Yeah. I don't know if you guys know the book. Very nice book. Butler and Mosley, Explain Pain Supercharged. Their book is about pain. Yeah, so I'm just going to hold this up here again. They wrote a book, of course, which is called Explain Pain, and the supercharged version is like for the applier, not for the patient. The other book is more for the patient, is because they're saying you can lose your pain just by knowing something. Yeah. So, and of course that's an aspect we need to consider, and I always like to consider that. I'm not a psychologist, but I think I worked my way pretty well into the field. But on the other hand, not to overdo it, so don't start to interpret something in a psychological way when it's not, because then you start telling somebody, well, you must have had a very bad experience, which is something that happened probably worldwide, but especially in the United States, like 20, 30 years ago, saying, oh, you don't feel well? Well, then you had a trauma in your childhood. Well, I don't remember a trauma. Well, that's because you didn't forget it. How do you say that? You put it away into your unconsciousness. Yeah. So that was a whole bunch of things where things were misinterpreted as being psychological, where they were absolutely not psychological. And that's also, I think, a very dangerous thing. So that's why my strategy is always, let's look at the physiology first, let's just look at your body functioning, and then we can think about what's going on in your head, and then we can think about strategies where you can change that. Yeah. Yeah. So that's, I love doing that work. Yeah. 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 Yeah, of course. Yeah. Yeah, and I think if that goes hand in hand, of course, that's great. I mean, that's because what you also know is that people with the eating disorders, they have some kind of misinterpretation of their body system. So what a guy in Germany here does, he fits them, he gives them basically like swimsuits, you know, the what do you call them, neoprene, which is like the wetsuits. Yeah, so very well fitted wetsuits to change the body feedback, to change the feeling of the body. Yeah, so to give basically it's proprioception. Yeah, so they're changing the proprioception, and that changes the way they feel and the way they eat. Yeah, just by doing that. So they're wearing their wetsuits and that helps them, obviously. So that's also very interesting, and that's something when I hear that, I think, well, can we fix that? Can we integrate it so we don't have to wear it all the time? So here's my thinking of, is it a dysfunction in body awareness, or does it really need to be trained? Yeah. So if it needs to be trained, a wetsuit is awesome. If it's a dysfunction, maybe I could just integrate it and there it is. So I don't need to wear the wetsuit for months to enhance the performance of my proprioceptive system, body schema. Yeah. So things like that. All right. Well, guys, I'm going to let you go now. I'm hungry, to be honest. Yeah, and but it was very fun having you, and this was not the only time. So we'll have more opportunities. I'm really looking forward to that, and you're very welcome to tell anybody you think might be interested. We can, but of course that will not be possible for a chat like we had right now. We can have up to 100 people in the webinars. That's at least what's technically possible. Yeah. So, but of course, this small round is nice. But if you know somebody from NIS that I might not know because you got to know them, or anybody else in your surroundings who's interested in medicine or functional neurology, maybe already, let them know. I'd be happy to give them some insight from my point of view here. Okay, so I want to thank you for coming here. I can't say that, for joining us here online, and I'll maybe see you very soon. And like I said, if you have some ideas, some issues you think might be interesting, and you would like to have my point of view on that, just let me know. Write me an email. And then we can pick up on that. All right. Thank you so much for coming by.